Hi, is Dr. G.V. Rao there? Yes, welcome. Thank you very much. A very good evening from Singapore to everybody. Welcome to this Olympus-sponsored symposium. It's my privilege and my honor to introduce our speaker today, Professor G.V. Rao. He is the Chief of Surgical Gastroenterology and Minimal Invasive Surgery Department at the AIG Hospital in Hyderabad in India. GV is known across the globe for big initiatives like nose surgery, among one of the persons in the world, or rather the few people in the world who've ever actually performed the nose. A great innovator, a great service provider, a great man at heart, and he's going to talk to us about innovations today as well. Professor G.V. Rao, over to you.
Thank you so much, Asim. Actually, thank you so much. Let me share the screen.
We can see your screen.
Yeah, 1 second. I'll just
go to PowerPoint mode.
Wait.
Just wait.
Yeah. Just give me a minute. Actually, I think it's.
So while this continues to play, I do understand at the forefront of technology, ICG is there. You being a laparoscopic surgeon and an endoscopic surgeon as well, have you seen it really change the way you practice across time?
Yeah, thank you, Asim. Actually, see, a lot of technologies keep coming in actually every day. Actually, we feel actually some of them could be industry driven, some of them are useful. We've been using this actually quite for some time actually, and then in fact, we had the prototype of the infrared scope from Olympus, which we had with us in our department for quite some, the first generation one. Actually, in fact, we noticed that actually a lot of times actually we have a subjective evidence of a lot of things that we do in clinical practice actually during laparoscopic. See, suppose you're checking for a vascularity of the bowel. I mean, it's basically a subjective evidence. We feel, okay, the pulses are great on the mesentery, or you check the bowel color. I mean, it looks okay. So basically now this has basically come as a basically a big advantage for us, wherein we are having an objective evidence of the entire thing right now. So that way actually, and we also noticed that actually whenever we are using this technology, we are able to document. Okay, fine. One, we are able to document. Second, yes, we are able to also very clearly shown that the leak rates actually following this actually or the complications following this, when you're using this are less. So I think the screen is on actually. So I'll
thank you.
Yeah, thank you. At the outset, let me thank both the ELSA, the executive, and also the Olympus team across the globe for this symposium. Now, gastrointestinal surgery has changed leaps and bounds actually from open surgery to minimally invasive surgery and endoscopic, also making a big roads into the management of various pathologies. And initially, when we switched on to minimally invasive surgery, laparoscopic surgery, it was the white light that we used to use in laparoscopic surgery. I mean, it changed from analog systems to then we have the high definition, then we had the 4K. The best part of this, what is happening across the globe, is this totally new integrated system of Olympus, which has come, which is a one-stop processor for everything. This is the biggest advantage that we have from the Olympus station, which makes it less space consuming, and then we have one system to handle the entire laparoscopic surgery. Now, if we go back to the physics of white light, actually we have been taught during our school, actually whenever white light hits against the prism, it splits into 7 colors. We call them as the VIBGYOR, or the VIBGYOR colors, starting from red, orange, yellow, green, blue, indigo to violet. And these basically have different wavelengths, and it has been shown that as the wavelength increases, there is increasing depth of penetration. So the more the wavelength, it penetrates deeper into the tissues, and we are able to see tissues which are not seen on conventional white light. So what has happened is, actually on the endoscopy side, we started using the blue light, which is for more superficial lesions, and on the red light we started using on the laparoscopic side, basically for more deeper visualization of various phenomena like the vascularity of the bowel and also various other pathologies. Now, historically, it was way back in 1852 that George Gabriel Stokes described the mineral fluoride emitting blue light when it is exposed to ultraviolet light. This is basically the beginning of how the entire ICG started, and he called this phenomenon fluorescence because it is emitting blue light. And the substances which have the ability to fluorescent are called as fluorospores. This is the terminology that is used. And currently, there are only 2 fluoropores that are approved by the FDA. One is indocyanine green, or ICG. The second thing is the methylene blue, or MB as it is called. Now, indocyanine green is a tricarbocyanine dye which fluoresces, that is emits light of excitation under infrared light, that is using a red light. It is highly soluble in water and binds to the beta lipoproteins, particularly the albumin. Because of the high protein content of lymph, ICG accumulates in the lymph node, lymphatic pathways, and lymph nodes. ICG-dyed lymph nodes become visible about 5 minutes after light excitation and remain visible for almost about 60 minutes. The intravascular half-life of ICG is about 3 to 4 minutes, and elimination occurs through the liver. So basically, if you understand this, then we'll know what time we have to inject ICG and how long does it stay, and do we have to repeat injection of ICG during the procedure. This is the basic, simple physics of indocyanine green. Now, this is the oldest fluorescent dye in medicine, approved by FDA, one of the first dyes approved, and it's both used in cardiac and liver function assessment. The spectral properties of ICG in NIG spectrum exclude the disturbing effect of all of this from hemoglobin, and the dosage is usually 0.1 to 0.5 ml per kg body weight. And the tissue detection depth, this is very important, is about 0.5 to 1 centimeter. This is comparatively more deeper as compared to the narrowband imaging. I'll just run some of these videos. These are self-explanatory.
Explains the process in different applications of real-time fluorescence imaging with indocyanine green in laparoscopic procedures. The new Olympus imaging platform, Visera Elite 2, is the ideal solution for real-time fluorescence imaging. Real-time fluorescence imaging can only be performed with infrared light. Therefore, a dedicated laparoscope and light source is needed. The infrared laparoscope uses a unique filter technology that provides a clear infrared image without interference radiation. The xenon light source provides a bright and clear white light image. During this white light mode, a filter is activated, which suppresses the infrared radiation to give a pure white light image only. Additionally, the light source delivers a strong infrared radiation. After switching to infrared mode, the filter in the light source changes. The infrared wavelength passes through and the red wavelengths are suppressed. Infrared radiation uses an optical window in human tissue to penetrate deeper cavities of up to 8 millimeters. Consequently, it stimulates the ICG that is bound to the plasma protein. The interfering reflected radiation is blocked by the optical filter to ensure a clear and distortion-free image. The fluorescence light passes through the optical filter in the laparoscope. This enables surgeons to work in 2 different infrared modes. IR mode 1, with high illumination to detect detailed structures even under infrared light. IR mode 2, shows the pure fluorescence mode with the highest contrast in a black and white image.
So basically, this is the setup that you call, this is the system that is this thing, and then it emits this red light. This is the processor that is used for it, and actually on the click of the thing, actually we change it changes the light mode from the conventional white light to the infrared mode. This is one of the best systems available right now. It totally one processor that takes care of the entire thing. This is the processor that is required for the infrared laparoscopy. Now this entire concept seems to have been derived from this movie called Predator, where infrared light was for the first time used to detect some camouflaged structures or aliens. This is a beautiful movie, science fiction movie, which showed this entire concept of infrared light. And I think this entire concept, what we're following, seems to be an idea that is borrowed from this science fiction movie. Now, this infrared laparoscopy is a very versatile technique. It's used for identification of HCCs, metastasis, hemangiomas. It aids in identification of biliary tree, ureter, lymph nodes, and it has subjective evidence of tubular organ perfusion, helps guiding resections and dissections, and there are increasing indications with technological advancements in this. But basically, diverse applications of angiography, cholangiography, and ureterography. Let's see how we prepare this fluorescent dye.
Dye is required for fluorescence imaging. The dye currently available in Europe for real-time fluorescence imaging is indocyanine green, in short, ICG. ICG absorbs the infrared radiation from the light source and emits longer wavelengths of infrared radiation. This makes it detectable in the human body, usually supplied as a dry powder. Sterile water must be added to the dye. The recommended ratio is 5 milliliters sterile water to 25 milligrams ICG. The ICG powder dissolves when the bottle is shaken. The dissolved solution is aspirated with a syringe and is then usually injected intravenously. The recommended dosage for cardiovascular diagnostics is 0.1 to 0.3 milligram per kilogram of body weight. The fluorescent solution enters the bloodstream and immediately binds to plasma proteins. On the monitor, a fluorescent image can be seen wherever ICG appears and is excited with infrared light. Finally, ICG spreads through the vascular system and is eventually cleared by the liver. The time frame of the dissolved ICG depends on the patient and procedure. There are 3 common laparoscopic procedures in which real-time fluorescence imaging can be used. These applications have been tested accordingly, and the results published in several studies. One application is resection in the lower or upper gastrointestinal tract.
So this is how it is diluted in the theater. Sterile is this thing actually, we take 10 ml of this thing and then dilute this in the thing actually. And then as previously shown in the animation, this is thoroughly shaken so that the entire thing is formulated. Then you take it back into the syringe. And then once this is ready actually, now we can inject that depending on the case that you're using, and the timing of the injection can be based on the procedure that you're doing during laparoscopy or even open surgery. Now, this is not only used in laparoscopic surgery, but it can be used very safely in open surgery too. The only thing is we are using the laparoscopy scope as the camera whenever we visualizing this, or even the camera head can be used for this. Now, let us see the applications of this actually in esophagus and stomach. Now, coloplasty is one of the techniques that is used for replacement to bypass the esophagus in several conditions, be it malignancy or benign conditions like corrosive injuries. We have had very good experience of coloplasty for corrosive injuries, because several suicidal corrosive injuries are seen in this part of the world, and these patients, many of them are not amenable to endoscopic dilatation. So they come for some sort of a coloplasty procedure, which involves taking in a part of the intestine, a large intestine, to bypass between the esophagus or the pharynx above to the stomach or the small intestine below. This is what is the colonic condo that is used. Now, this procedure, we in our department actually, whenever we have actually during the initial feeding jejunostomy, whenever we do this for these people with corrosive ingestion, we do an ICG, I mean the ileocholic ligation, basically to make sure that we get good blood supply collaterals from the other parts of the right colon. We use right colon as a colon conduit in our department, basically because the ileocecal valve, which is intact in these things, prevent reflux of these contents. And whenever we're doing priming this colon with previous ileocholic ligation, we feel that the results are very good, and we have a randomized trial which showed that whenever we did IC ligation versus no ligation, and we wait for about 4 weeks, the results are better, the leak rates are better, and the conduit seem to be acting very well. Now, this is one of those patients. Actually, you can see this. We mobilize the thing. This is the ileocholic vessel that is being ligated initially. In spite of this, this is adequately perfused. Now, this is the colon that is taken up above now. It is placed over the chest. Now, it is reaching onto the cervical end. Now, we can see this. This is the ileocholic thing that is tongue that is being divided. And we have, this is the ileal part, the ileocecal valve, and the right colon here. And then when we inject ICG, you can see this bowel is absolutely very well perfused. There is no changes of any ischemia anywhere in any part of this entire conduit. And then we are very sure that it can be safely used for this. And you can see this conduit now has come through the pre-sternal route into the cervical incision. And you can see this is the ileum that is coming out of the cervical incision. And then we recheck again to make sure there is no compression. We use this ICG at various stages. This is because it is going through the retrosternal space. We want to make sure that there is no compression on the conduit, which could lead to some sort of an ischemia later. So we injected again ICG to make sure that the conduit is functionally viable, and it shows absolutely fluorescing very well. These are the, I mean, we use this in various steps. I mean, before, after we tunnel the substernal space, once the conduit goes to the substernal space, it comes into the neck, we make sure that it is adequately perfused. Again, we see this. This is subjective evidence to show that some pulsations are there. Again, we're making sure that inject ICG, and then again we show that this bowel, the conduit is absolutely very well perfused. And then this is anastomosis that is done. Actually, majority of our patients who come to us have a very high stricture. So in fact, we do a pharyngo-ileal anastomosis actually, because even the post-cricoid area is involved. This is the thing again to show that the bowel is very well perfused and the cut ends are very vascular. And then once we are very comfortable, we know that there is no torsion, twist of the conduit in the retrosternal space, then the anastomosis is complete. And even after completion of anastomosis, we recheck again, making sure that both at the anastomotic site is very well perfused. And you can see this is the anastomosis that is done. And then we inject ICG again to check the integrity, to check the vascularity or the perfusion of the conduit and the anastomotic site. So this is, and also sometimes whenever we do that here, you can see this anastomosis being done to the esophagus. So now we can check the integrity of both the esophagus and the ileum. So we inject ICG again here to make sure that this conduit is a viable thing. Now you can see this, both the segments are very well perfused. So whenever we have done this, actually, I mean, IC ligation in our department, we found that the leak rates are less, and this conduit is very well primed, and it gets adequate collateral so that the leak rates are less. And ICG has tremendously helped us in making sure that at various steps it is used to make sure that we are having a perfused, very well perfused conduit during the entire procedure, especially when we are taking it along the retrosternal space. We make sure that there is no compression. And even sometimes we excise the medial and the clavicle if there is any compressive effect to show that is objectively shown on this indocyanine green fluorescent. Stomach is again very well perfused actually. The ICG is not that very useful to check for the vascularity of the stomach, basically because it is heavily perfused by vessels. We all know that it is supplied by 4 major vessels, so the bowel the gastric vascularity is tremendous. And so that even if you major dissection done, the stomach seems to be very, very well perfused. But especially when you're doing this D2 gastrectomy, this is one video which showing that we do this the D2 gastrectomy under ICG mode to pick up all the nodes which are not conventionally picked up on conventional white light. We know that we're clearing of the entire, bearing all the vessels and then making sure that the entire lymphatic field is cleared and blocked. But we also use ICG to make sure that we are not missing any lymph node during this entire dissection. And at the end of the procedure, at the end of the T2 gastrectomy, you can see this, the entire lymph nodes have been cleared. But to make sure that this is a complete dissection, now we inject indocyanine green, and then we check that the stomach that is, again, as I told you, it's heavily perfused, so it perfuses very well. And we check this entire bed wherever the D2 lymphadenectomy was done, and we showed that there is no lymph node that are left behind in this area of dissection. You can see this is very, very clear. And if there are any nodes, residual nodes, we can always pick them up again in the dissection. So this is the big advantage of using indocyanine green during D2 gastrectomy. You can see this absolutely, the entire field is clear. There are not a single node that is fluorescent during this entire procedure after the dissection. Colorectal surgery, it is being used immensely and very, very common procedure that is done and is being used extensively in colorectal surgery. And not only that, colorectal surgery is becoming one of the most important specialties, and it is almost become a gold standard now that minimally invasive surgery has almost completely replaced open surgery because of data coming in that showed that colorectal surgery is best done minimally invasive.
Such as the resection of the esophagus or the colon. In this video, we will explain the application in colorectal surgery. Here, the fluorescent solution is injected intravenously as described before. The dye binds to plasma proteins and immediately shows the vascularization. The well-perfused parts are bright green, and the ischemic parts are not green. There are numerous indications that demand a partial resection of the colon, such as in colon cancer, polyps, or inflammation. After the dissection of the target area, the diseased part of the colon is located in conventional white light. The arteries leading to the colon segment that has to be removed are clamped, and the diseased part is resected. ICG can be injected and used to control the perfusion of the two open ends of the colon before the stapler is used. This helps to identify the perfused stapler line. Ischemic parts of the colon show no signs of green fluorescence. To prevent anastomotic leaks, the ischemic parts have to be resected as well. The next opportunity to use ICG is after performing anastomosis. Dissolved ICG can be injected again to check if the colon is well perfused around anastomotic site. Before the injection, the surgeon should check if there is any fluorescence dye left from the first injection.
So you can see this is one such procedure. We are using the ultrasonic shear, the thunderbeat. This is one of the phenomenal advances that have happened in minimally invasive surgery. This has really changed the way in which we do dissections during laparoscopic surgery. Thunderbeat from Olympus is one such innovation. And you can see this is these are the plumes that are generated during this entire thing. This is the inferior mesenteric vessel that is vein and the artery that are being skeletonized. And then once this is done, and then we mobilize this entire thing, actually, you can see this, these are the plumes that are generated, and the dissection is almost complete. We can do the entire surgery with just one instrument without having to change to other instruments. Actually, biggest advantage actually of using this instrument, very versatile instrument and very stable. And the blades are, I mean, the compared to the other competitive brands, the blade, the ultrasonic shears, if you see the tip of the thing, is absolutely very well designed. And the angle is very well used for dissections, for hooking up structures, for creating planes, and also for it also helps like a retractor. We can just push it down. You can see the tip is slightly angled below. That helps in basically the dissection going in the direction, and it also helps in pushing the tissues away from the line of dissection. So various advantages. The design of the scope, the design of the thunderbeat is basically absolutely a phenomenal thing that is designed for one instrument that can use various stuff. The tip is designed in a way that we can hook up structures. The angulation is good, and in spite of having a curve at the tip, the ultrasonic energy seems to be traveling very efficiently through this entire curve, and there is no loss of any of these desiccation, even at the tip of the thing. You can see that even the tip of the instrument seems to be functioning very well. You can see that the tip, we're just using the tip, and the tip is phenomenally working very well. So this is the beauty of this, and this is being used in this. And then once we transect that, that is how it is done. And then, and you can see this. Now this is the, now we inject indocyanine green again, and then we check. That is the ureter there. And you can see that this is another video to show that the bowel has been dissected actually. Now here we inject indocyanine green now to check, as mentioned earlier, to check the perfused colon versus the non-perfused or the dissected, or where the vessels have been ligated, en bloc ligated along with the lymphatics. You can see now, this is an objective evidence to show that you can transect here, and distally you can transect here, and again this is very well perfused. So this is very, very helpful to make sure that we are not stapling an ischemic bowel, so that we don't have to revise the margins again. And again, now this is again post anastomosis, the staple anastomosis being done. Once this is done, again we can inject indocyanine green. The staple looks very good, but we have the leaks are predominantly basically because if the stump is not adequately perfused, or the cuttings are not adequately perfused, the leak rates could be higher. And again here we show objectively that these both transected ends at the anastomosis is adequately perfused. Now this is showing some compressive effect of the stapler. Now once the stapler is released, then we'll be able to see in an absolute good perfusion across the anastomosis. And there is a lot of data to show that ICG is very useful in identification of ureters. This is one of the commonest injuries that can occur during laparoscopic surgery. So injection, sometimes we have a lot of techniques to identify, prevent injuries to the ureter, but ICG injection seems to be one of those non-invasive. You don't have to put in a ureteric stent to identify this, and then it's one of those non-invasive things, and it's an integrated system so that we don't have to keep switching from technique to technique, or we don't have to depend on other specialties. Now we can identify the ureter directly by switching the mode to the IR mode. In some of these colonic cases, we directly inject it. See this, to pick up the sentinel node, we inject the dye directly into the lesion here. This is under colonoscopic guidance. Actually on table, we are injecting indocyanine green, and you can see this, it fluoresces immediately, and we pick up the sentinel node in these things. And then the dissection can be an absolutely complete dissection in this. You can see that's the lymph node, how it is picked up. So this is the beauty of using this intralesional injection, and then that is the root there near the IMA, and then we have the node there which is picked up, and then now we make sure that this entire lymph node comes out along with this vessel. Now this is one such procedure, a transanal procedure, TEMS procedure that is done, and usually the distal end vascularity is subject to it's an subjective thing that we do, but here we have an objective evidence to show that we've injected ICG. You can see this is very, very low, the stump here, and you can see this is absolutely perfused very well. This is a transanal mesorectal excision that was done subsequently to check whether the distal stump is now adequately perfused. We used indocyanine green, and it shows very well adequately perfused. And here, this is one again after a transanal anastomosis. Again, you can see this beautiful anastomosis done through the TEM procedure. And again, we inject indocyanine green. Again, you can see this stump, which is initially perfused. Again, it is very, very adequately perfused. We are worried about the proximal stump also. Now that the proximal colon, again, you can see this is absolutely beautifully perfused. So this anastomosis is absolutely very well perfused, and the leak rates or the stricture rates in these are very, very low. See, the commonest thing that can happen is the leaks or the strictures, and if the bowel is adequately perfused at the site of anastomosis, these two complications are very, very less. And there are a lot of data coming up from across the world. This is Professor Sakai, who has published to show that following high anterior resection, actually the results are very good using IR. Recently, we had a case of pseudomyxoma peritonei, actually appendicular malignancy, which is into the peritoneum. So we've done actually ICG in this, and then you can see this. This is the omental nodule which is picked up on ICG. I'll just show you the thing actually. Now these are the omental nodules that are not picked up on conventional white light because they're very vascular. Once we injected indocyanine green, they are picked up on this thing. So we did an ICG guided targeted biopsy. And this is the mucinous material seen in the right iliac fossa. And you can see this is the initial part of the injection that was done. And then we'll see that it beautifully, that's the liver that is fluorescing very well. And then we picked up peritoneal deposits. This is the white light again. And then you can see this, we have done ICG guided biopsies from the peritoneum to confirm this. So you can see this, actually these are the ICG guided biopsies that we have done to confirm. So this is the first ever time that we are showing the use of ICG in pseudomyxoma peritonei, basically because the bowel things from the metastasis from the bowel, this seems to be enhancing very well, and ICG guided biopsy seems to be very apt, and we have confirmed this histologically. Also, these biopsies have gone and they've confirmed the diagnosis of pseudomyxoma peritonei with omental peritoneal deposits. And you can see this. This is the pillar 2 study that has shown that the perfusion assessment of laparoscopic left-sided and anterior resection is absolutely ICG is very well useful in this, and lot of data coming up from across the world showing that ICG fluorescence imaging for quantitative evaluation of colonic perfusion. I mean, I'm sure you're talking about the quantitative evaluation, not the qualitative. So now once we quantified or objectively tested this, I told you that the outcomes are better, the leak rates are less, stricture rates are less in these things. Hepatopancreaticobiliary surgery, again, one of the initial usage of ICG was in HPB surgery, predominantly while doing cholecystectomy.
Again, the fluorescence solution is injected intravenously. The surgeon has to wait approximately 45 minutes for the dye to reach the liver and clear into the bile ducts. Since ICG binds to proteins in the bile, the infrared image allows a good view of the site and shows Cowlitz triangle even under the fatty tissue. IR highlights the structures of the ducts and helps to identify them. Without fluorescence imaging, the common bile duct is sometimes misinterpreted as the cystic duct. With infrared fluorescence imaging and ICG, it is much easier to distinguish between the ducts. Both cystic artery and duct are clamped, cut, and the gallbladder can be removed. Consequently, this standard procedure is made easier. Again, the fluorescence solution is injected intravenously. The surgeon has to wait approximately 45 minutes for the dye to reach the liver and clear into the bile ducts. Since ICG binds to proteins in the bile, the infrared image allows a good view of the site and shows Cowlitz triangle even under the fatty tissue. IR highlights the structures of the ducts and helps to identify them. Without fluorescence imaging, the common bile duct is sometimes misinterpreted as the cystic duct. With infrared fluorescence imaging and ICG, artery and duct are clamped, cut.
So ICG has improved visualization of the biliary topography during laparoscopic cholecystectomy. There are umpteen number of studies that have shown that the visualization of cystic duct is better when ICG is used, and it is better than intraoperative cholangiogram. And it is said that it's likely that ICG can replace intraoperative cholangiogram. I think we still have to run some randomized controlled trials to show this. But as of today, at least in our center, whenever intraoperative cholangiogram has to be used, we have replaced it completely with ICG, and we're absolutely very happy with this. And I'm sure whatever has been said, I think ICG would clearly replace intraoperative cholangiogram in future. It is also being used in liver resection. Again, a beautiful study by Ishizawa, which has shown that during laparoscopic liver resections, metastatic lesions can be picked up, and following resections, leaks can be identified on table and they can be secured, so that the incidence of post-operative biliomas is less in these patients. And you can see these various segments being visualized. The segmental anatomy can be very well visualized, and resections are possible, both anatomical, non-anatomical, and basically best because we are minimizing the leaks following these liver resections. The leaks are tested on table. You can see this is a leak that is tested on table following resection, and we secure all the bile ducts that are not conventionally seen on white light. Initially, there was a lot of apprehension about using indocyanine green in pancreatic surgery, but infrared intraoperative imaging of pancreatic neuroendocrine tumor seems to be the in thing. Now it seems to be picking up actually. Initially, because whenever we used to use ICG to visualize pancreas, we could not get good images, but especially for neuroendocrine tumors, it seems to be very useful to localize the tumors, and following this fluoresces much. And then subsequent, suppose if you're doing some sort of an enucleation procedure, we are very, very sure that the entire tumor has been removed. So it is being increasingly used for treatment of NETs actually, and indocyanine green loaded hyaluron-derived nanoparticles for fluorescent-enhanced surgical imaging of pancreatic cancer. Now, this is one of the newer emerging modalities that is being used, so increasingly used for pancreatic cancer. So, but we just have to wait some more time to see how this can be used. And with more and more data coming in from the other centers, I'm sure in the days to come, we can use this very liberally even for pancreatic surgery. And as I told you, anastomotic leaks are one of the commonest nightmares for surgeons for any anastomosis, be it a gastrojejunostomy or an ileostomy or an ileocolostomy or a colocolostomy or a coloanal anastomosis. This is one of the most alarming complications. And by using ICG, it has been shown that we can decrease this leak rate. Now, this is one such incident where using ICG to check the integrity of the rule limb that we created for hepaticojejunostomy. We are very sure that that is the area of transection we have to make. And then once you're sure that the leak rates following this or the stricture rates following this would be very, very low. Now, basically we have this robotic assisted ICG versus regular laparoscopic cholecystectomy. Major bile duct injuries are avoided whenever we are using ICG, and it can also be used for preoperative colonic tattooing like we use for infrared. We can always use, and then we have some clips also available right now which can be clipped through endoscopy or colonoscopy so that subsequently it can be visualized. Now, it is used extensively during transplantation in benign biliary stricture to identify ducts which are not visualized on white light, and also identify the post-operative leaks following anastomosis. Now, as I told you, ICG is also used for checking liver metastasis. Intraoperative ultrasound does not detect less than 3 millimeter lesions. Superficial bind area up to 1 centimeter under the liver surface, but dye is retained in some stromal tissue between the tumor and the normal tissue, and ICG seems to be picking up these lesions very well. Now, thunderbait, actually, as I told you, this is one of the very good thing that I've shown you earlier. Again, the video to show how you dissect the inferior mesenteric pedicle, the artery, vein, and how this entire instrument is used for dissection, hemostasis, one instrument for the entire procedure. Now, this is a very, very versatile instrument. The tip is absolutely phenomenally designed to do the procedures, be it colorectal procedures deep in the pelvis or in the abdominal structure, or whenever we're doing a transarterial procedure, or also whenever we're using a thoracoscopic procedure. This one instrument seems to be, the design seems to be a phenomenal thing which takes care of all the dissection in all planes, in all types of dissections. Now, what are the surgical plumes that are generated by this? Actually, if you see, the surgical plumes that are generated by ultrasonic scalpel about 0.535 to 6.5 microns. And there is a lot of apprehension about these surgical plumes that are being generated, especially in COVID times. People are worried about COVID transmission from the patient during these plumes. And there is the pneumoperitoneum that is created is an aerosol procedure, and there is the risk of aerosol exposure to the healthcare workers. And these energy sources, all the energy sources can produce large amounts of surgical fumes, and we should have ways and means to minimize this aerosol into the operation theaters. And sudden release of trocar valves, non-airtight exchange of instruments, or even small abdominal wounds that are used for extraction can cause aerosol dissemination. So we have to use safety mechanisms like filters, traps, and carefully deflating the trocars. But these are very, very difficult to implement. But we have one of the best solutions that has come up with from Olympus is this integrated smoke evacuation system. You can see this is integrated. The insufflator has got an integrated smoke evacuation system, which is what is responsible for keeping the field absolutely clean, and the vision is absolutely phenomenal. And even when it is done under low flow, and if you're using the suction, the vision and the pneumoperitoneum seems to be maintaining very well, because it's an integrated system. Suppose you have a separate system that is used for smoke evacuation, obviously it is not integrated to the system, and it is likely that this other smoke evacuating devices which are attached to this could be sucking the air or the gas from the abdominal cavity at higher pressures, and it causes rapid deflation. So this integrated device is absolutely a phenomenal thing, which is an insufflation, desufflation machine, and also evacuates the scope and keeps the field absolutely clean. Now, there are some endoscopic fluorescent clips that are used for localization of tumors in laparoscopic surgery. Some of these actually during endoscopy and laparoscopy, some of these tumors are picked up. But when we try to do a laparoscopic resection, these are not palpable or visible. But using these endoscopic clips, now it is very, very easy for these lesions to be picked up on ICG laparoscopy. Now, so as I told you, basically initially, the vascularity of the bowel was a subjective thing. Now it's an objective thing. So I'm sure in the days to come, we have artificial intelligence which gets integrated into this. And I'm sure then we have an absolute artificial intelligence data to show that this is a perfused organ and how much it is perfused, and what is the amount that is required, how much of it is perfused, and what are the leak rates or the stricture rates that are going to happen. So I'm sure in the days to come, we'll see more and more of AI which is getting integrated into this, and we'll see more and more of this ICG being used in clinical practice. What is the future of ICG? Now, these are bright for molecular NIR fluorescein guided cancer diagnosis and therapy. Increasingly, I think they'll be used for cancer diagnosis and therapy. The nanoparticles containing fluorescent dyes are being developed that include bioactive ligands which target tumor-specific peptides to deliver therapy and track response to the therapy. So it is possible right now that in future we have this ICG which can be tagged to this so that it gets absolutely localized, and then can absolutely check it, make sure that this the medicine has reached the tumor. So to conclude, ICG enhanced surgery can be applied during different procedures, both open surgery and laparoscopic surgery, offers additional information to the surgeon on anatomy, perfusion, and lesion identification. It has potential benefits, and this is very, very safe procedure, and can expand current capabilities by development into smart and targeted fluorescent molecular probes and highly sensitive imaging equipment that allows recording of fluorescent signals at minute accumulation. These are all the things possible. Actually, we have standardized the procedure now with more and more refinements, and the next generation IR equipment that is going to come. I think laparoscopic surgery is going to become safer and better. And I'm sure like endoscopies, now it's mandatory that we integrate the narrowband imaging into all systems. Olympus has integrated narrowband into all endoscopy systems now as a part and parcel of imaging. So I'm sure in the days to come, we'll have IR, which is permanently integrated, and we'll be using these IR scopes completely, which will replace the previous set, so that we'll be using these IR dependent scopes in future. Thank you so much once again for the patient hearing.
Thank you very much, Dr.
Asim, yeah.
Yes. Thank you. That was a long, lengthy presentation, but thank you for summarizing the use of ICG in clinical context today. I just wanted to pick on your experience, as you've mentioned, for the pseudomyxoma peritoni.
Yeah.
Have you tried it for other kinds of carcinomatosis? Is it equally effective?
Yeah, I think we haven't checked it for colorectal, but this is the first time actually when we wanted, this was a clinical diagnosis of pseudomyxoma peritoneae. We wanted an ultrasound guided aspiration. We could not get it. Then we had to do a diagnostic laparoscopy to confirm. So, I mean, we checked, we didn't hope for anything, but when we injected ICG, it's a phenomenal images that we got. Those omental things which are not picked up on white light were picked up on this ICG. And we're able to do that ICG guided biopsies.
Where do you see the future in terms, currently we are practicing lymphadenectomy, a sentinel lymph node biopsy for adequacy of clearance is something we're using this. Do you see it becoming a hallmark of diagnosing metastatic like breast cancer? You know,
Yeah.
Take that. Do you see it becoming somewhere there?
Yeah, I think, see, actually this, we see a lot of these nodes which get involved, the primary nodes being spared and the secondary nodes getting affected. We have a lot of literature to show that actually. And then some of these patients seem to be coming back with recurrence actually. And see the extent of lymphadenectomy also, there is a lot of controversies again, depending on whether this lymph node has to be removed, this station has to be cleared, this station is, you know, that for every procedure we have so many pros and cons actually. But these are again, some people say, okay, you do this lymphadenectomy, this is absolutely all right. But even following that routine thing, suppose you do inject, suppose if you're picking up some of these things, I think it aids in improving the outcome. So I think definitely it is going to be a big game changer in oncological practice. And I think it will become a part and parcel of the algorithms in the lymph nodal dissection. We do beautiful dissection. I mean, we've seen a lot of surgeons beautifully bearing the entire vessels and showing the thing. But one or two nodes that has been skipped in the primary en bloc resection may be catastrophic in long term. So these can be picked up on ICG.
Thank you. Thank you very much. I have a question for you from the audience, and it is, what is the organ-specific time for ICG?
Now, it's a variable thing from, as very clearly shown in the animations in this thing. Actually, for vascular, it's almost immediate. For biliary tree, if you have to visualize, it's minimum 45 minutes that we have to use. Even if, suppose if you inject almost about 3 to 4 hours earlier, also the bile duct gets filled up very well. 45 minutes later, even the liver fluoresces. But if you wait for about 2 hours, the entire liver is excreted and only the bile duct is completely fluorescent. And in colorectal, it takes about 3 to 4 minutes to get the thing. It is basically from what you're visualizing, either the vessel, the vascularity, or the excretion. Excretion takes time, whereas vascular things are almost instant.
And for lymph node dissection, what's your practice?
Yeah, lymph node dissection, actually, suppose you want to, as I showed you, suppose if you want an intraoperative thing, actually we can do it before induction. During induction, it can be injected. Or intralesionally, we can inject. Suppose if you're not able to visualize, intralesionally, we can inject to pick up these nodes.
Okay. Do you see any downside apart from the awkward allergic reaction to it? Do you see any other downside of using it?
Actually, this dye has been extensively used in ophthalmic practice. Actually, though there are some reported side effects, actually, we've been using this almost for more than about 2 years right now. We have not encountered any major issues regarding this. Seems to be a very, very safe dye. Other than the images, I mean, maybe the images, I mean, with more advancement, we'll get better images actually. But actually, otherwise, I did not see any major disadvantages with this.
So have you used this concurrently, like for lymph node dissection and anastomosis concurrently, based on time phenomena that you have explained?
Yes.
So it's feasible to do that.
It's able to do that. Yes, absolutely. And I mean, doesn't seem to be any we almost use sometimes, actually, I showed you in the colonic round, we almost inject about 3 or 4 times. You understand? So absolutely, there seem to be no side effects using this because it immediately gets flushed out from the body almost immediately. So that unless until some of this, it could be stay slightly longer in the kidneys or the liver, but from the vascular system, it gets flushed out immediately.
So I have another question from the audience. Would you use this for open surgeries as well?
Yeah, actually, see, basically, it is very useful for laparoscopic surgery, but especially for, as I showed you, we've used it for coloplasty. Yes, open surgery, it can be used. Whenever, suppose you have to convert a laparoscopic procedure into an open procedure, yes, we can use it. Any of the open procedures, suppose you want to check the vascularity, yes, actually it can be used. But a person who has got an infrared laparoscopic system in his theater obviously will be doing more laparoscopic surgery than open surgery. But it is certainly an aid. Whenever we have this, we can always use it for open surgical.
So in your opinion, this is an additional tool to the normal standard precautions and procedure techniques we use to ensure a perfused anastomosis, a good staple line, and a common staple wound. Would that really summate things?
Yeah, absolutely. Actually, initially it came in for bile, like bile leaks, identification of bile. Actually, that's a phenomenal thing. Actually, it completely avoids, you need not have any C-arm in the theater. You don't have to worry about the radiation. You don't have to worry about any of those things. So on one side, bile duct surgery becomes very, very safe. Liver surgery becomes safe. Colorectal surgery, esophageal gastric surgery is safe. Now, the only thing is we have to get some data about pancreas now. All other things seem to be safe except some data which we need to get from regarding pancreas.
Well, thank you very much, Dr. G.V. Rao. It was very interesting, very educational presentation. We thoroughly enjoyed it. Thank you for sharing your great experience with us. And we hope to see you soon. Thank you very much. Once again, thank you, Olympus, for arranging this event for us. Have a good day, and we shall wait for us to go back to the main auditorium. Thank you very much for this.
Thank you, Asim. Thank you so much.